Good evening, everyone. Today I would be speaking about evolution of hemispherotomy, starting from the large open techniques to the minimally invasive strategy and finally culminating in the bloodless technique that we have decided. And this is a journey of 15 years. So there are no disclosures, and that is the first case of hemispherotomy which we performed way back in 2002. Soon afterwards, we published the first series of hemispherotomy from India. And I would do both the lateral as well as the vertical technique till in a case of hemimegalencephaly, following a lateral technique, the patient developed a large venous infarct for which a decompressive craniotomy had to be done. And the patient was discharged several weeks later on a tracheostomy in a very suboptimal condition, which led to my thinking that it would be imperative to develop minimally invasive strategies for hemispherotomy because most of the patients we do are kids who are just 4 years or 5 years of age. Now, this is an example of a vertical hemispherotomy which I did more than 17 to 18 years ago, and you can see there has been an excellent improvement, and after 5 years you can see that the deafferented hemisphere has undergone disuse atrophy while the power itself continued to improve. So in brief, this lecture is going to be mitrist with epilepsy surgery for 25 years and 4,500 cases, and particularly this lecture is going to deal with my own journey on developing minimally invasive strategies for hemispheric surgery. So in the evolution, where do we start? So we start somewhere in 350 BC by an assumption by one of our fathers of medicine, Aristotle, who said that you cannot create a vacuum within the human body because a vacuum in the human body is not compatible with life. So that was the assumption by which we started. So it was as early as 1888 when Grolls performed the first hemispherectomy in a dog, and the dog survived. In fact, it was wagging its tail and was able to eat food. And then finally, it was Walter Dandy who performed 5 hemispherectomies in patients with glioblastoma multiforme. One of these patients survived to as long as 3.5 years. And it was Mackenzie from Toronto who did the first hemispherectomy in 1938. Now, following this, Krainow from South Africa performed piecemeal hemispherotomy in a series of 8 patients. And then, of course, the technique of en bloc hemispherectomy was developed by French, Obrador, and ultimately Rasmussen. Now, this went on for quite some time till Oppenheimer described cerebral hemosiderosis, which could be found in about 15 to 30% of cases. And if it indeed does develop, it is fatal complication, which could have 100% mortality rate. And people understood that because of large cavities within the brain is the reason for cerebral hemosiderosis to develop. And now surgeons started devising techniques by which the vacuum or the empty space in the brain could be minimized. So one technique was to create a large extradural space. The other technique was to plug the foramen of Monro with a piece of fat, and so on. And of course, the technique of hemidecortication was also developed, which was also an alternative to do an hemispherectomy. Finally, in 1974, it was Rasmussen who developed the technique of functional hemispherotomy, and subsequently 2 techniques developed: the vertical technique primarily by Professor Delaland, and the lateral technique primarily by Villemure, later on with modifications from Schramm, Shimozu, and Mayera. Now we need to understand that the indications for hemispherotomy could be widely heterogeneous. It could be something as straightforward as a post-infarct condition to something as complex as hemimegalencephaly. And likewise, the outcomes of these pathologies are also not equivalent. So post-infarct has the best possible outcomes. Rasmussen has an intermediate outcome, whereas hemimegalencephaly has the it has the least possible outcomes. This was the largest study called as HOP study, which was done for hemispherotomy, in which our center also participated, which clearly showed from a series of 1,267 hemispheric surgeries that the best outcome is in fact for post-infarct, which is about 80%, and the least is for hemimegalencephaly, which is for about 60%, and intermediate is Rasmussen's disease. And vertical techniques for the first time has been shown to be better than a lateral technique, likely because we go through a totally avascular plane and the insular disconnection is not an issue, which could be an issue. Leaving a residual insula could be an issue with lateral techniques. The overall class 1 outcomes for hemispheric surgeries for all categories in the study was shown to be around 64%. Now the question is, why minimally invasive? So we published this landmark study where we did the first ever randomized controlled trial for epilepsy surgery in kids. And we demonstrated that children who undergo surgery have a tenfold better outcome than children who undergo just medical treatment. And this study has over 700 citations as of now. But more important, we demonstrated that the cognitive deficits do not improve despite doing surgery at a later stage. Hence, from this study, it became clear that children, when indicated for epilepsy surgery, should undergo surgery as early as possible in order to prevent epileptic encephalopathy. Hence, it's very clear that when you tackle patients who require hemispheric surgery in children who are around 4 years, 3 years, or even 1 year of age, it has to be done as early as possible. And paradoxically, it is the maximally invasive surgery for the most maximally possible pathology in the brain. So we started thinking about minimally invasive strategies. And initially, when we started thinking about endoscopic techniques, it sounded as difficult as trying to pass camel through the eye of a needle. So we did have our own learning curve. So initially we started with both lateral as well as vertical techniques. And then I switched over to an interhemispheric technique. And finally, we settled to an endoscopic technique, which could be done with an aid of an endoscope attached to a robotic system through an opening of 3 into 4 centimeters. So unlike Delalande's technique, we approached this from a frontal corridor, whereby we were able to reduce the footprint of hemispheric disconnection by almost 30%. And we have done around 76 cases with endoscopic hemispherotomy. And I'm going to show a short video. Apologies that it will run at 4x speed because the time is short. Now here, the first thing we do is retracting the hemisphere to one side. This is a highly magnified view of an endoscope, so you don't see the ring around. So we separate the A2s, and then we start cutting the corpus callosum in between the A2s. It goes from genu till the level of splenium, and the splenium has to be disconnected completely. Then we come to the front, visualizing the genu as well as the A2s. And then we start the anterior disconnection, which passes in a coronal plane, starting from the genu laterally up to the lateral part of caudate head. And then we start lateral disconnection, which passes lateral to the caudate head and thalamus, goes down to meet the temporal horn. And here we disconnect the hippocampus, head to the hippocampus as well as amygdala. And finally, we do the posterior disconnection, which is disconnecting the temporal efferents, which consists of tail of the fornix and tail of the hippocampus. So we published this. We presented this for the first time in 2014, and thereafter we published our technique in several papers. So initially we started off with atrophic pathologies where it was more easier to do this technique. And then we progressed to more complex and more non-atrophic pathologies. For instance, this is a hemispheric cortical dysplasia, and you can see the beautiful disconnection here. And this is a hemimegalencephaly with frontal horn aplasia, one of the most complex pathologies. And we did this case in Malaysia. The child lost just 40 cc of blood. He was having about 300 to 400 seizures a day. And just by using the endoscopic technique, we were able to provide a very optimal disconnection, and the child was seizure free. And some of the caveats were that we were able to develop endoscopic assisted corpus callosotomy, which could be combined with anterior, hippocampal, and posterior commissurotomy, described in the literature for the first time for severe Lennox-Gastaut syndrome. And with this, we showed that we were able to stop the drop attacks by almost 100% of the cases. And this is how we did. And of course, following this, we also contributed the chapters to various textbooks. And it was also taken up by other authors and surgeons elsewhere in the world. And finally, it came into the chapter of Professor Pete Engel's textbook of epilepsy, which is considered a Bible for epilepsy. We also described for the first time the importance of the temporal stem, which is present anterior to the amygdala, which was earlier not described by Professor Delalande. So when you do the vertical approach, most often we leave this piece of tissue, which is temporal stem, which is anterior to the amygdala. And we found that in our failures, we went back, and whenever there was a residual temporal stem, we went back, and when we did surgery, we were able to enhance our outcomes from 80 to 90%. And this we published it in Neurosurgery, Journal of Neurosurgery. Hence, with our experience of endoscopic hemispherotomy, we demonstrated that it was a safe, effective, and a minimally invasive technique, which could be done for all spectrum of pathologies. There is definitely a learning curve attached to it. And by addressing the residual temporal stem, we were able to enhance our class 1 outcomes from 80 to 90%. And even if a repeat surgery was required, it was usually straightforward and simple. because already a large cavity has been formed within the cranial cavity. But the question is, do we need to evolve further? So there are various reasons why we felt that we need to evolve. Firstly, because it requires tremendous experience for anybody to use an endoscope to do hemispheric disconnection. It just cannot happen without any element of training. So you need to have a lot of experience with endoscope handling, and only then you will be able to do an endoscopic hemispherotomy. And personally, I had an experience of over 1,000 endoscopic surgeries before I could do such complex endoscopic disconnections. And there is a definitely learning curve attributed to this. So we have to understand that any new techniques that we devise should be easy enough for a majority of the surgeons to do it. Only then it could be applied to a majority of the patients. And I believe firmly that the best of inventions were easy for majority of the people to use or physicians to use. So we decided to evolve. And then we developed this robotic guided thermocognitive hemispherotomy. And we published it in JNS. And this also came up on the cover page, where using robotic guided radiofrequency ablation, we performed an hemispheric disconnection. And we called this technique as ROCH, which stands for robotic thermocognitive hemispherotomy. Now, incidentally, ROCH also stands for a small Arctic bird, which is common on both coasts of Atlantic in winter. It's also called as little auk. Now, how did we get this idea? Now, for quite some time, we published this also. For quite some time, we were treating hypothalamic hematomas by doing a radiofrequency ablative disconnection. So that's a pre and post-op. Again, this is a pre and post-op. So when we were operating a giant hypothalamic hematoma, I got an idea that if we moved a bit more laterally, we will be able to provide a very nice hemispheric disconnection. Then we started calculating the strategies. And of course, idea was born because we had a robotic device. We were able to fuse both MRI and CT scan because we had a ROSA as well as an OAM. And we also had very good quality generators. And then on calculating on MRIs, we found that the hemispheric disconnecting footplate is just 1/5 that of the cortical footplate. So it's not difficult to provide hemispheric disconnection. The only issue is that the planning has to be absolute. The planning has to be very good. So we planned in the same manner that we would do endoscopic surgery. So we planned that the middle disconnection can be achieved through 7 to 10 trajectories. The anterior disconnection could be achieved by 3 to 4 trajectories. The temporal stem and amygdala could be achieved by 3 to 4 trajectories. And the corpus callosum can be disconnected by using 4 oblique trajectories. So using a total of 15 to 20 trajectories and about 100 to 130 burns, we will be able to achieve a good hemispheric disconnection. And of course, before we did this, we applied for ethics committee clearance. We got the clearance. And we developed this X technique, whereby through a single twisted hole, we could establish multiple diverging trajectories, which could provide a complete planar disconnection, producing this beautiful hemispheric disconnection. Now, I'll show you the technique. The technique, when you see the surgery, it's not much. It's only the planning, which is very, very important. Otherwise, the whole procedure just consists of putting the adapter directly with this flush with the skin, drilling directly through the skin, coagulating the dura, and then passing the electrode at various points, burning it at an interval of every 3 to 4 millimeters, so that one can obtain a complete planar disconnection. So we use an OAM fused with MRI for one of the sections so that we have a complete good accuracy. And we burn the lesions for about 75 to 80 degrees for about 1 minute. And when we withdraw, we inject glue. So you can see there is not a loss of single drop of blood. For sake of modesty, we said that the patient loses less than 5 cc of blood, but truly speaking, there is no loss of blood at all. So a few examples here, you can see the disconnection which has been done in this atrophic case. And the patient was having about 30 to 40 seizures a day. And that's at 3 months. The child was walking well. The hemiparesis did not worsen. And the child was seizure free. Few more example, a case of hemispheric cortical dysplasia. Again, 12 to 16 seizures with a very nice hemispheric disconnection. Another patient of a large frontoparietal FCD where it did a hemispheric disconnection. And that's a child post-op. You can hardly make out any scars. And then few more cases, a case of post-meningitic with very good disconnection. Patient of Rasmussen, again with very good disconnection. Now this patient developed some edema on day 3. Now this was a patient where we had to do the technique of Roch 2 times. So this is during the first time, he used to have 20 to 30 seizures. He improved significantly, came down to 1 to 2 seizures a week. And we found this residual disconnection. We tried Roch a second time, it didn't improve much. So finally, we did an endoscopic surgery, which was very straightforward. We just had to introduce the endoscope and then disconnect the small flap, following which patient was seizure-free. So we performed Roch in about 32 patients. Currently, it's become the sole procedure of choice. The age range from 5 months till 20 years, including all spectrum of pathologies. 29 out of 32 patients have had class 1 outcome. And using the X technique, we were able to reduce the duration of surgery to just around 4 to 6 hours. We had to repeat surgery in 3 patients. One patient underwent Roch twice, followed by an endoscopic hemispherotomy. The complications were minor, including one small hematoma temporal lobe leading to a transient third nerve paresis, another small hematoma which improved by itself. And in one patient, he developed edema following the technique of Roch. So in non-atrophic pathologies, we cover them with both steroids and mannitol and repeat a CT scan on day 3. And this resolves. Within 5 days, this resolves. We have found Roch to be very, very satisfactory. The recovery is excellent. As soon as the surgery is over, the patient opens his eyes because there is no hypothermia, there is no blood loss, there is no complication of hydrocephalus, and there is no fever. So right from day 1, the patient is completely afebrile, unlike even endoscopic technique where patient continues to have fever for 5 or 6 days because of seepage of blood into the ventricle. So Roch has been found to be gentle on brain, gentle on children. It seems to be very promising and an effective technique, leading to class 1 outcomes in 29 out of 32 cases. It's the most minimally invasive bloodless surgery. There are no infections, no fevers, and up till now, we've never seen any complication of hydrocephalus. The repeat surgery, if necessary, could be done easily, and the skip areas could be tackled. Now, the long duration of surgery has been reduced using the X technique. And for countries like India, where financial issues are always very, very important, it costs us just $50 per patient because we don't use any consumable parts. So once we have purchased the robotic system and a generator as well as an electrode, you could use it for multiple surgeries. So our cost to the patient comes to just about $50 per patient. And of course, this was also published in Times of India because it was a very new and innovative technique. For me personally and professionally, it's been a great source of satisfaction because I come from an era where I used to see a hole in the brain. And to be involved personally in developing a technique where this maximally invasive procedure has been reduced to just one line in the brain, I think has been the greatest source of satisfaction for me. So in the evolution of hemispherotomy, we have contributed for development of minimally invasive strategies, which include endoscopic hemispherotomy, further evolving into the technique of Roch. But thump our chests as we might, I still feel that we are in this part of the evolution where we are still learning how to grapple with our tools. I think there is a lot of exciting future and a lot of exciting developments which are waiting to happen in the future. Now, this quantum of work would not be possible without the help of team effort. So with this, again, I would like to thank the entire committee, organizing committee, for having given me this opportunity to share my experience and this unique innovations. Thank you very much.